Hello. Today, I know we had a good lecture the last time. This time, we're actually going to talk about a couple other things. One of the things that we're going to talk about today is the peripheral nerves. Specifically, we're going to start off with the autonomic nervous system and then migrate on to other things. So we have a bit of time that we need to spend with this. So be careful that the time is going to be a little bit more longer than the last time. So I just want you guys to be aware of that. So when we look at the autonomic nervous system, basically what we're looking at is those nerves that actually affect us for homeostasis. So in other words, it keeps us in line with what we're actually doing without thinking about it. It's not this, and I want you to compare this to the somatic nervous system in the peripheral nervous system. So the somatic nervous system is basically where we're actually looking at skeletal muscles rather than involuntary muscles. So I want you to realize that that's where we actually have to look at. So it's a subconscious control is basically what we're looking at. When we actually look at the autonomic nervous system, it can affect different parts. So we actually look at glands, the heart, and other organs of the viscera. We're not talking about the muscles, where we actually usually think of most of the time. So I want you to realize. But here's the thing: even though most of us don't even think about this, it affects our limbic system, which means it affects how we may have emotions and how we actually may interpret those as far as an overall in our conscious portion of our body too, not just our subconscious. So I want you to realize this is one of those things. So we do actually have it looking at and I want you to think about it when we're actually looking at these nerves. A lot of times we also can look at afferent and efferent neurons. So just so to refresh your memory from when we were looking at the kidneys, you might have remembered that we talked about afferent and efferent at that point. So afferent affects it, efferent is affected by whatever is interpreted. Okay, so I want you to recall that. So when we're actually looking at the comparisons, like I said before, we have to compare the somatic with the autonomic. Somatic is skeletal muscles, autonomic is involuntary muscles. So I want you to think about that. And somatic is all excitation. But autonomic, we have both excitation and inhibition. So these are things that can happen in a normal sense. So I want you to understand that those are very important to conceptualize the differences. So when we look at autonomic, we can actually have what we may actually see as an excitation, which will increase our viscera, or we can actually have something that may be more along of a decrease or inhibiting the aspect of that organ. So a lot of times when we look at the autonomic, it has both going on. So it's important to realize. And when we look at the somatic, one of the big things that also happens is somatic, we actually have it affecting by a single neuron, as opposed to autonomic, where we actually see it where we have two neurons that are actually motor neurons that are affecting those visceral muscles. So I want you to think about that as something to realize that's going on. A lot of times, what happens is the first neuron is actually going from the central nervous system, or more specifically from the spinal cord. It's myelinated, and it will go to a ganglia, and the ganglia will then start off with a second autonomic neuron, which could be non myelinated. That's one of the reasons why, if we actually think about our visceral muscles and how they're stimulated, a lot of times it takes a longer time frame than it does for our skeletal muscles or our somatic nervous system. So I think this is rather important concept to realize of why there's a difference in timing. So if we looked at this diagram, you see the top diagram, you see the bottom diagram. Look at those. Notice that on the top one, we're looking at a somatic drawing. The bottom one, we're looking at an autonomic drawing. Notice in the drawing itself, you'll see that the somatic drawing actually is seeing one neuron coming from the spinal cord out, as opposed to the autonomic, where we have the first neuron coming out to a ganglia, and then we have a second neuron that's going from that ganglia, where we start off with the cell body and it extends out to the visceral organ, which is unmyelinated. So that's rather important to understand conceptually. So when we're looking at the basics of this, we will actually have two neurons, a preganglionic neuron and a postganglionic neuron. Now, one of the things that you might also want to recall from the past that we talked about was that the preganglionic neuron is a B fiber. That means it's myelinated. And the postganglionic neuron will be a C fiber. Remember, and it's unmyelinated. And remember, I told you guys not to worry about those names as much, but you would see it. And this is where you're seeing it. Okay, so just keep that in mind. Um, so, going on, if we look at a different diagram, this diagram, on the other hand, is actually showing differences within the autonomic nervous system. So, let's really look at what we're seeing here. If we're actually looking at this carefully, what you would notice is the first diagram and the second diagram are related. Now, how are they related? Is they are actually part of the sympathetic, and I'm trying to draw a sim so you guys can recognize, as opposed to the bottom drawing, which is parasympathetic. And I'll try to write para on there for you guys. And of course, my way of writing it is kind of unusual using this pen. But what you'll notice is that one of the things that you'll see is the ganglia in the sympathetic actually extends to a certain point, and then we have it relatively at a different point than the organ itself in most cases. When we're looking at it as far as the second drawing, you're seeing the adrenal medulla. But when we actually see the release of that, that is actually releasing substances that are similar to neurotransmitters, like epinephrine and norepinephrine. So that's something to keep in mind. When we look at the lower drawing, the parasympathetic drawing, you'll notice that the ganglia is closer to the organ itself, the visceral organ itself. So that's an important feature to know about. So let's see. So when we're actually looking at these drawings, basically what you'll see is it's divided up into two sections. That's what that's saying. Here's a nice drawing that I like. This drawing is really important because it actually compares the sympathetic and the parasympathetic. On the right, you see the sympathetic, and right on the left, you have the parasympathetic. One of the things you'll notice is that the sympathetic actually is coming out of the thoracic and the lumbar regions of the spinal cord. You'll also notice that the parasympathetic is coming out of basically the cervical and the sacral regions. But you'll notice if you're looking to the sides, it actually has a different effect on each organ. So if we looked at, let's say, right here, we see the parasympathetic is reducing the heart rate, and the sympathetic is raising the heart rate. So it's having the same effect on the same organ, but a different effect itself. So it's an antagonistic effect, which is that's important to realize that when we look at the differences between sympathetic and parasympathetic, it is antagonistic, but they're coming out from two different parts of the spinal cord. And that is an important thing to remember. And that's something to consider when you're actually studying. When we actually were to look at, um, let's say, going on, one of the things you'll notice is that your book actually shows it more like this. As the divisions, this is the where it says the sympathetic and parasympathetic. Notice when we actually usually think about it, sympathetic, you're increasing the rate of the body. Parasympathetic, it's slowing it down. As we talked about, sympathetic, fight or flight, which means you're actually in a more stressed or a more alert scenario. Whereas parasympathetic, you're more looking at a more relaxed state. When we look at the divisions, one of the things that you'll notice, sympathetic will actually have ganglia also. One of the things that we see is the sympathetic has a trunk ganglia or vertebral chain ganglia or a paravertebral ganglia. They're all the same. It's just different terms for the same thing. And one of the things that we also see is that sometimes we have other ganglias, like the celiac ganglia, the superior mesenteric, or the inferior mesenteric ganglia, which are specialized for certain parts of the body. Um, Parasympathetic also has ganglia, but they are terminal or intramural ganglia, which are very close to the visceral organ that they actually are affecting. These are examples would be the ciliary or pteropalatine or the submandibular or the odic ganglia. So they're closer to that organ that they're actually affecting. So one of the things that you'll notice, it also refers to these ganglia as having dual innervation. So basically what that means is they actually come out of different parts of the spinal cord and they actually affect the same organ, but in different ways. So that's that antagonistic pairing aspect. So when we actually also look at the nerves, one of the things that happens that we don't always think about is that they actually come out of the spinal cord and then they actually create plexuses, just like we saw previously. We have autonomic plexuses. These plexuses are going to affect the nerves that are going to eventually go out to those organs. So a lot of times we actually see that a lot of times the autonomic plexuses will go to a specific location or specific organ. When we look at the autonomic plexuses, like the cardiac plexus, it goes to the heart, affects the heart. The pulmonary plexus affects the lungs. The solar plexus or celiac plexus will affect the internal, the upper um, abdominal area. The superior mesenteric and inferior mesenteric and the hypogastric plexus, those are affecting different organ areas. When we also look at it as far as the parasympathetic, it has also plexuses. Those same plexuses can also affect the organs. So a lot of times when we actually look at these plexuses with their effects, the structures of the sympathetic nervous system will actually have a variety of things. So I just want you to recognize that this is something that you may come in contact with at some time down the road. Um, so when we're actually looking at the postganglionic neurons, one of the things that you might want to see is that the postganglionic neurons um, will actually have a couple approaches to what can happen. They can go directly out from the spinal cord directly to the ganglia. They can go into the ganglia and then or out to the organ itself, which is what this is saying. They can go into the ganglia and go up or down, or they can actually go and go to a different location. So if we were to look at this diagram, what do you see? Well, one of the things that you see is this. You might notice that we have this particular neuron, and it goes out to the ganglia, and it goes out to another ganglia before it affects the organ. So that's the first thing. We can actually have it going out to the ganglia, and then after it gets out to the ganglia, it actually goes up the trunk ganglia or down the trunk ganglia before it goes out to the organ or to the ganglia itself. Or what happens is it goes along the ganglia to another point and can go back up to another spot. So let me try to get another color for that so that you guys can see this. So it goes from here in, and then it goes around and up, and then comes back down to create another plexus. So there's three different things that can actually happen there. So this diagram is kind of useful for that. Um, your book has this particular one where it actually shows it's at the same level, up or down the spinal nerve, or it can also go out to the ganglia. So when we're actually looking at sympathetic nerves, they can affect things where they, like you might think about, it'll increase the heart rate, it'll increase the breathing rate, it'll increase your blood flow. So that's something to realize. You'll also notice that when we actually look at it and we look at the plexuses, one of the things with sympathetic nerves is we actually, and this diagram really shows where we actually have that trunk ganglia. So if you were to look carefully, and if we were able to do this, you would notice that right along here, you'll see the trunk ganglia on one side and the trunk ganglia on the other side of our major organs, the aorta, the esophagus, and such. And what we would actually notice is that each one of those locations, you'll see a ganglia here. Well, let's see if I can draw it in properly. Right in this area, a ganglia here, ganglia here, 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 here. Those are there are, and if you also look on the other side, it's here, 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 here. So when we're actually looking at it, this is one of the things that's useful to understand about the sympathetic nervous system. It has these ganglia. The ganglia is also intertwining its nerves around all the major organs. And so what happens is a lot of times it can also have an effect on what those organs will have going on in the viscera. And this is one of the reasons that when we are actually looking at the visceral organs, that a lot of times when they get excited or stimulated, they're more on the alert type mode or that fight or flight mode. And so what happens is it also then has a generation of effects to to the somatic nervous system and how you actually may think about things. So that's rather important to understand. When we look at the circuitry, it can diverge, which means it splits apart, and it actually goes to multiple organs. The adrenal gland, one of the things that happens with the adrenal gland, it releases also epinephrine and norepinephrine. And you might notice that they also linger in the system. So that actually creates more of that fight or flight or that actually alertness that we need to consider. One of the problems with it in an application is Horner syndrome. This is where one side of the face can actually get affected, and the innervation of that side will cause a loss so of facial activity. So that gets us now to parasympathetic. Parasympathetic, like I said, is more that relaxed state. One of the things that we see is it comes out of the sacral and the cranial nerves or the cervical area. So when we're actually looking at it, it does have a different locational effect. And if we were to look at it's one of the things that we would see is that we also see it affecting the eyes, the face, the tongue, the glands of the saliva glands, and so it can also affect the heart rate. So when we're looking at it, it does actually have quite a few different organs that are affected. The same organs that are in the viscera that are affected by the sympathetic nervous system, but now we're actually looking at a more relaxed state. So, this more relaxed state will actually have a different effect. It also takes longer to do. One of the reasons is because of the types of neurons. So, in the nervous system, when we're looking at the autonomic nerves, we do actually have effects that we can see that they have the different neurons. We have adrenergic neurons and we have cholinergic neurons and with their neurotransmitters. So when we're looking at the differences, basically what we're seeing is most of the preganglionic neurons will release acetylcholine, which is what you see in both of these images. But at the ganglia, we can actually have the postganglionic neuron will either release norepinephrine or it will release acetylcholine. And they do actually have names for these also. I'm not going to ask you to worry about these names for the neurons or for their types of receptors, but you may come in contact with this at some point in time in your future. So when we do look at the cholinergic neurons, one of the things that we see is they release acetylcholine, but one of the things that we also see is they can excite and they can also inhibit different organs. Cholinergic neurons, what we can see is we also have nicotinic and muscarinic receptors. And it's the nicotinic that will be more excitatory. And so those are the ones that we have to think about that we've come in contact with, especially when we looked at the neural muscular junction. Muscarinic receptors, on the other hand, will excite or inhibit, and that we may see in other areas of the visceral organs. Adrenergic neurons and receptors, a lot of times they release norepinephrine. So it excites and it can inhibit some organs. But they also will have the norepinephrine will linger. And when it lingers, it will require enzymes to break it down, like MAO or COMT. So when we're actually looking at it, one of the other things that we should also expose ourselves to, so we're more familiar with neurons, is that adrenergic neurons and their receptors can have three types: alpha 1, beta 1, which excite, alpha 2, beta 2, which inhibit, and beta 3, which we actually see happening when we actually have brown fat, when we're actually using temperature changes. So when we're a baby, we actually have brown adipose tissue, which we don't have when we're an adult typically, and we burn it off. And so basically, that's what the type beta 3 are infected by. Okay. Um, like I said, one of the things that we also see, the receptors, the neurons can be antagonistic. So when we're looking at these two types of neurotransmitters, they can actually have an antagonist, which could actually basically have an effect of binding and blocking the neurotransmitter that's normally there, or antagonistic. The agonist, on the other hand, will mimic the neurotransmitter and it can actually increase the effect. So, a lot of times when we look at drugs, and I want you to realize when we look at neurotransmitters, a lot of times drugs will actually represent and actually have similar molecular structures as one of these neurotransmitters. So, it can actually affect it like an agonist or can actually affect it like an antagonist. So when we're actually looking at these, a lot of times the overall effect is physiologically really looking at how do we affect the body so that we maintain your balance and your homeostasis. Remember, most of the time we're not always excited and actually stressed. There are times that we are also able to relax, and that's important that we can actually also get that relaxed state of mind too. So basically, the effects of the autonomic nervous system is to maintain and to actually have that balance of what's going on. Um, when we look at the sympathetic responses, though, like I said, that's typically that whole fight or flight is that we keep hearing about. And that fight or flight is actually going into those E situations where we actually have physical or emotional stress, where we have an emergency, embarrassment, excitement, or when we exercise. And basically, what happens is we're looking at decreasing blood flow and decreasing the effects of the non essential organs at that time, and actually getting more blood flow to those organs and those structures that may allow us to escape a predator or allow us to gain our prey. Remember, this goes back to evolution when we were actually in the savannah of Africa. And in the savannah of Africa, the grasses were only about, let's say, 3 feet high. And you actually had to either hide in the grasses to actually prevent something from eating you, like a lion, or hide in there so you can actually not be detected so you can get some sort of food for yourself. So that's where it actually stems. And I want you to think about this. Think about if you were in a situation, and you guys have seen these situations, you get bunked by somebody else, someplace in, you don't expect in the past. Like when you're celebrating, well, you could either just brush it off or you can actually create a one of these scenarios and then try to either fight the person or just run away. And it goes back to that type of scenario. So when you're looking at these sympathetic responses, it actually is a means of survival if you really think about it. Whereas the parasympathetic is that more relaxed state. So you're actually looking at what's referred to as the rest and digest. And I want you to think about this. That means in the parasympathetic, you're actually having salivation, lactation, urination, digestion, defecation. You're basically in a relaxed state so that you can actually have those functions occur. Most of the time, when you have a sympathetic occurrence, you don't feel like going to the bathroom. And you'll notice most people will not have that happen, except if there's paradoxical fear, where there's no way of escaping. So if you see that whole scenario of having an animal caught in a corner of an alleyway and there's no ways out, that's where it loses control and it soils itself, shall we say, or a person even. So most of the time, we don't see that occurring under normal circumstances, except in a paradoxical. So it's something to keep in mind. So knowing the differences between parasympathetic and sympathetic is important. So how does this physiologically affect the body? Well, basically, it affects it by actually preparing us in a fight or flight for an emergency, but it also allows us to conserve energy when we're having a non-emergency situation with the parasympathetic nerves. So when we're actually looking at it, we do actually have reflexes of this system too. So a lot of times when we do see these effects, you're looking at changes to the muscles based on what the sensory is. So we actually have the sensory receptor, the sensory neuron, the spinal cord affecting it or an integrating center, and then we have the motor neurons and then the muscle itself, which is the visceral effect. How do we control it? Basically, our hypothalamus controls what goes in and what goes out, which then affects the various visceral organs. And a lot of it is also related to things like temperature, blood rate, blood pressure, respiratory rate. So those are all factors. And smell, taste, temperature, and what's affecting to the blood will be affecting this. So when we're looking at the sympathetic nervous system, these are where we actually have one neuron affecting that organ, motor wise. whereas the autonomic, we have two neurons. So those are important things to remember. What can be a problem? Well, we have problems like Raynaud's phenomena, which is where we actually have excessive sympathetic stimulation to smooth muscles. And this is where you will actually notice people will actually have cold, cold hands when they get emotional. Um, we can also have autonomic dysreflexia, which means that basically they have exaggerated responses with the sympathetic nervous system, and it can cause a vasoconstriction of their blood vessels, and which can elevate the blood pressure, and it can cause pounding headaches, and it can cause an ischemia, which would cause a possible stroke or seizure or heart attack. Okay, so I hope this was helpful in this sense, but we're also going on a little bit so that we can actually get a little bit more as far as the what actually can affect the peripheral nervous system a little bit more. So let me just readjust this slightly so that you guys can see. So we're looking at also what happens with the integration systems, what happens with the motor neurons and the sensory neurons with the receptors. Now keep in mind, we actually have receptors that will actually get the information. And even though we've been talking about it and we've talked about it and we've seen it, we don't always break it down into different components. So it's important to understand where that information is going, where it's coming from, how does it get there, and how does it affect the body. So one of the things that we see is that when we're looking at it, we have to look at the different aspects. What are the levels and components of sensation? What is the pathway that we use for sensation? How do the pathways affect the motor signals to the body? And what is the integration process, which means what is our wakefulness and sleep? And how do we learn and what is our memory related to this? And how do we actually gain more memory? Okay, or as far as what we learn. So sensation basically is our conscious or subconscious awareness of stimuli, internal and external. So that's important to conceptualize. Now, when we actually look at the sensations, one of the things that you might also want to think about, it's different than perception. Perception is your awareness and interpretation of that sensation, as opposed to just receiving that stimuli. So this is where it's important to realize that there are different type of stimuli or receptors. We have chemoreceptors, thermoreceptors, nickel receptors. Now, what is a nickel receptor? It's pain. Baroreceptors, which are pressure. And I want you to realize that a lot of times it will actually go into different things. So we don't have receptors for things that we can't identify, like ultraviolet light. But there are organisms like some birds and some insects that can identify ultraviolet light. We can't identify certain sounds, which maybe if you have a dog, you might recognize they have a wavelength of sound that they can actually hear than we can. So that's important to also understand. So we can only identify what we're able to identify. And a lot of times we may look at what's called modalities. Modalities are just what is the sensation? Is it touch? Is it pain? Is it temperature? Is it pressure? Is it vibrations? Is it vision, which is light? Is it hearing, which is another vibration? So a lot of times we actually get it into two main categories or classes, which means general senses and special senses. What are the general senses? General senses are things temperature, pain, pressure, vibrations, and they affect all over the body, not just specifically at one spot. Special senses, we're going to talk in another chapter, but special senses are related to specialized organs with specialized receptors that detect only those things. Most of the specialized senses that we actually have are all in our head. No, it doesn't mean in our brain. It means in our skull, we have the special senses. We don't have them distributed throughout the body. General senses, they're distributed throughout the body. So that's important to realize that we have. Um, so when we're actually looking at the general senses, um, they can be somatic, they can be visceral. Most of the ones that you think about are visceral or are somatic because they affect the skin. So I want you to realize that. Special senses, will actually have a couple of them that you may know of. You have smell, which is actually olfactory, taste, which is gustatory, vision, which is sight, which is in the eye. So far we've looked at smell being in the nose, taste being on the tongue, vision being in the eye, where we actually can see what I'm going to call black or white, as which is just detection of light, as opposed to color light. And there's three types of colors that you should be aware of: red, blue, and green. We also have in the ear hearing and equilibrium. And there's two types of equilibrium that we're going to talk about. One that I usually refer to as rotational as opposed to linear, which is really called dynamic and static equilibrium. So when we're actually looking at the sensation though, a lot of it relates to we have a receptor, it gets stimulated. That receptor then stimulates a neuron and it gets to the basically where it needs to go. And it can actually have that impulse being varied based on how much of the stimulus, if it's graded, and how much we can actually get a generation of the impulse. So when we're looking at the receptors, general receptors, basically we have it in a lot of times somatic, which means, like we said, skeletal muscle, and there's no specialized structures. And sometimes we do have specialized structures, and we'll talk about those, as opposed to the special senses, which actually all have very complex structures. So, our eye, our ear, our tongue, and our nose will be specialized to get the vision, hearing, taste, and smell. Um, Another way, we can also look at the receptors in different ways. We can look at how its structure is, we can look at the type of responses to stimulus, what the location is, and what is the type of the detection. So we'll look at each very quickly. So if we looked at them, we actually can see the structural classifications will be we either have free nerve endings, which we see with pain, temperature, tickle, itch, and light touch. We can have encapsulated nerve endings, which we actually have more for vibration and deep touch. And we can actually have separate sensory cells. These are the specialized cells, or specialized um, sensory. So I want you to realize that we'll get to them when we get to the specialized senses more. So if we looked at this diagram though, the top diagram is free nerve endings. Notice at the end, we actually have the end of the neuron, this end, excuse me, where we have just a nerve ending. The second one, we have an encapsulated structure. And on the third one, we actually have specialized receptor type structures. So that's where we actually see them. Um, we can detect, we can also look at it by different ways that they're classified by the stimuli. So we can have mechanoreception, thermoreception, nicoreception, photoreception, chemoreception. Mechano, Mechanoreception is basically where we're looking at pressure, touch, tickle. All those can be actually mechano. Okay. Thermoreception is looking at temperature. Nicoreception is damage to tissues and cells, where we get pain. That's the key. Remember, pain is useful. We have photoreception, which is basically with light, and chemoreception is chemical changes. Smell, taste, those are chemical. We can classify it by the stimuli. Was it a generator potential? Was it a receptor potential? Do I want you to worry about those? Not at all. But I want you to realize that they do have different effects. And when we look at generator potential, we're looking at first order neurons. And, the receptor potentials are more the specialized receptors, and they may actually have more complex type design. They can be classified by location. So we have exoceptor receptors, which are on the outer portion of the body, which is exposing you to what's on the outside, as opposed to intrareceptors, which are within the body. We also have the proprioceptors, which is basically related to, like I said, positioning of the body. So proprioception will actually give you detection of how your body position is at the muscle, at the tendon, at the nerve, and this also affects your equilibrium. So that will also affect you. So a lot of times you'll notice proprioception, you will actually see. You could be in complete darkness, but you actually can identify whether your body is sitting, standing, leaning against a wall, or some other position that you might want to think of, whatever that may be. We can also adapt to sensory. So, one of the things that happens is when we actually adapt, we can adapt slowly or quickly. So, what does that mean? That means how much do we decrease the amplitude of that stimulus? And when we do adapt, that means it affects how long we actually come with that stimulus. So, one of the examples is we adapt to smells very quickly. So that means when you get an odor, whatever the odor is, you smell it, and then a short time later, you don't notice it. Whereas so this is one of those rapid adaptation type receptors, where slow adaptation, you notice it and it continues prolonged, like pain. Pain you will actually notice if you have pain. It shows up. It continues. You ever get a tooth pain? You'll notice it pains you a long time. It doesn't just go away quickly. And a lot of it is basically related to how we adapt so that we can survive. This is also rather important as far as our adaptation, as far as our homeostasis and survivalness of us. So that's why it's important. When we actually look at the somatic sensations, we're going to see tactile sensations. Tactile is touch, pressure, pain, vibrations. And vibrations can include itch and tickle. So we have a variety of different receptors, which are listed right there. So you can actually notice them. I wouldn't worry about them specifically, but you may recognize them, and we'll go over some of them. So when we're looking at touch, touch can be crude touch or discriminate touch. Crude touch is just you notice your body pressing up against something, like you're sitting on a chair. You notice that you are sitting on a chair. You feel the chair beneath you. Discriminative touch is fine touch, which relates to fine motor skills, which means it actually interprets little details of objects as your position is. Typing, piano playing. These are all related to discriminative touch and actually identifying fine motor skills. So that's why it's important to recognize that they're interrelated. Okay, so we do actually have certain receptors involved in that. When we look at pressure, pressure can actually be more sustained over a long period or long area of the body. So that's why that's important. Vibrations, you notice vibrations being a sensation with repetitive signals, which could be tactile. And itch and tickle. Itch and tickle are related to this because basically itch is essentially the same as tickle. The only difference is tickle is affecting you from someplace else, from somebody else. but it's causing you that itch sensation, that vibration type thing. So if we were to look at the different parts of this, if we looked at the skin, we see Meissner's corpuscles, which are deeper. Um, this actually gives you more of the discriminative touch. Now, I don't want you to worry about all these terms as far as the different types of receptors. I'm exposing you to it so that you have a more specific understanding. So that when you're going through it, if you need to look at it in the future, you'll know what receptors are affecting you so that you have that knowledge or you can find that easily. Okay, so Meissner's corpuscle is one of these. This is encapsulated. It's in the skin. Hair root plexus is free nerve endings. They're surrounding the hair follicle. Merkel's disc is flattened out. It has dendrites, and it actually creates 25% of the receptors in your hand. Ruffini's corpuscle, it's found in deep dermis of the skin. It's for heavy touch and pressure. Parsinian's corpuscle, this looks like an onion. It's also an encapsulated structure, which is for high vibrations and sensations. So when we're looking at all that collection of different types of receptors, they collectively create your tactile sense. So I want you to realize, so touch is crude. Touch can be that overall. Discriminative touch, you're able to distinguish more. This is one of the reasons that when you look at your labs, you'll notice that there's 2-point touch where you're trying to distinguish two different points and how far away they are or how close they are. So you'll notice in the fingers and in the hand, they're much closer than you might even notice in your wrist. Pressure is sustained over an area, vibration is repetitive, and itch and tickle are basically vibrational type things which are affecting the free nerve endings, but itch is where you don't actually have somebody tickling you. Tickling is basically itch from somebody else. Thermal. Thermal is the second one, which is basically temperature. So when we're looking at this, this is also free nerve endings. But one of the things that you'll notice that you recognize when it's cold, you'll recognize when it's warm. But basically, you're looking at a change of about 20 degrees. And that's how you actually identify that there is a difference in temperature. So when we're looking at it, though, cold will only affect certain temperature ranges. Warm will affect certain temperature ranges. But when we actually look at it, you can also get pain if it's below 50 degrees or above 118 degrees. And it will cause you pain. And you can recognize that. Pain is also another thing. Pain is related to nickel receptors. And nickel receptors are basically free nerve endings that have adapted this pain. And it is actually related to a lot of times muscle spasms, inadequate blood flow, and one of the biggest ones is tissue injury, where we actually cause a release of kinins and prostaglandins that stimulate nickel receptors. And also potassium can also be released. So one of the things that happens is, which is why it's important to understand this, is that we have to look at the types of pain. So we actually have acute pain, which is basically where sudden onset, and it feels like a needle piercing through your body, but it's not felt for a long period of time. We also have chronic pain, which is slow pain, or where it actually increases and intensifies and throbs like a toothache. And it can affect visceral or locations and deep structures. So those are important to understand. But not only that, how do we affect pain? Pain can be affected by a variety of reasons. So we can look at how we can actually look at the superficial or the deep pain differently and how it affects the body. And it helps us to identify what's wrong with the patient. So if we're looking at a patient, we can actually see that that pain can be localized or it can be over a generalized area, and that we can actually look at what's called dermatomes to actually identify what organ may have been affected by that pain and where that pain is affecting, and which may help us to identify what the organ is. So a lot of times when we do that, we say that's referred pain. So if we were looking at the referred pain or the dermatomes, it actually gives us those indications like we saw the last time. We have a heart pain, and the pain goes down our left arm. Now keep in mind that's a generalization. It's not always the same for every individual, as we notice in newer information. Females may have a slightly different way of that effect. But as a generalization, we do see this. If we get lower abdominal pain across both sides and on our flanks, that may indicate that we have a kidney problem. So I want you to realize that this is something that is generally known. And what do we do to get the relief? Well, we can actually have different types of ways of affecting the pain. So if we were to look at affecting the prostaglandins with the nickel receptors, we can actually have aspirin and ibuprofen to block the formation of the prostaglandins. Some of you may be familiar that we can block the conduction of the nerve by actually giving Novocaine or a Novocaine derivative. We can also have lessening of the perception of the pain in the brain by giving morphine. This is one of the reasons that if you look at most epidurals, and most epidurals will actually use morphine as part of the anesthesia so that it blocks the perception of that pain. So, one of the other things that we also see is proprioceptor receptors, which is basically those receptors that affect our kinesthetic sense, which is basically positioning of our body. How do you know that when you're actually going to move, how to move, where you're going to move, or what muscles are going to be moved, and how much? And so you don't fall over and lose your balance. So this is important to understand. So when we're looking at that, a lot of it you might want to refer back to those receptors that we looked at in the last lecture. So when we're looking at it, when you walk, you're walking. You put one foot in forward, but you're actually holding your body up with that one foot without falling over. Well, it's your proprioceptors which will actually detect which changes you have to make so that you can actually put that one foot in front of the other rather than actually having a problem. So it goes into that Golgi tendon organ, it goes into the joint receptors, it goes into the pressure receptors of the joint, it goes into all those different structures, tendon receptors. So I want you to realize those are all related to it. So you can actually have the joint receptors that are in the joint that actually detect different pieces of information. Now, keep in mind, I don't want you to remember those specific names because I don't think if you want to learn that and if you wanted to actually get into more of that information, that you can actually refer to it at some other point. Um, when we look at the pathways, we actually have the neurons going first order, second order, and third order. Well, basically, what does that mean? Well, where is it going from primarily? So we're looking at the primary somatosensory area of the cerebral cortex. That would be first order. Second order is going further down, let's say into the cerebellum. And then third order, we're going from there down to the rest of the brainstem. So basically, that's what that's also referring to here. But here's the thing, we do actually have some details that we're going to talk about. That's only so that you have an exposure to it, not to actually remember every detail. But if you were going to help patients and to identify what's wrong with those patients, some of this information is rather important to understand what's wrong with the nervous system if they are having problems with movement or with balance or other things. So I want you to realize that even though we're looking at these details in a greater amount, it's important to realize that you will not need to know this detail all the time at this point. Okay, so you want to make sure that these you understand the concept of it overall, but not the details of what they are. So it's not going to be on a test. So we have fine touch, stereognosis, which is basically your ability to identify left and right, proprioception, and vibration sensations. So when we're looking at the Lenniscus pathway, what we're seeing is some of your pathway will go from your first order to the second order, and then from the third order, where it may actually um, it may cross over and go through the rest of the system. The anterolateral pathway, which is also very similar, but this is actually where we're talking about pain and temperature and tickle and touch. When we're looking at the spinal thalamic pathway, this is actually looking at pain and temperature, tickle, touch, crude touch, and pressure. But you'll notice it goes down and it accosts at the spinal cord, not in the uh, not in the medulla or in the thalamus. Now, one of the things that's rather useful as far as understanding the somatic sensory is looking at the the cerebrum and looking at the primary somatosensory area or the primary where we actually can see. And this diagram does not actually show us exact, but you might notice that here we actually have the hand and here we have the arm, but you'll notice the hand is bigger than the arm, which actually gives you a representation of that there's more receptors and more somatosensory indication from the hand than we see in the arm. This is one of the reasons why we can actually see our fingertips feeling much more and being able to distinguish more. That fine motor skills, in other words. So and that's why braille has been also been used for this. So I want you to think about that. This actually affects it. It could also affect the cerebellum, where we actually have the ability to distinguish which muscles to actually stimulate. And so when we actually look at the routes for the proprioception, we can actually look at these routes right here. And like I said, I don't want you to memorize all this. I just want you to recognize and have the concept of it. How does it affect us clinically? Well, syphilis is one of those progressive degradation type diseases. It's caused by a bacteria known as Treponema pallidum. Treponema pallidum, one of the interesting things about it, it actually is a spirochete. It has primary syphilis, secondary syphilis, tertiary syphilis, quaternary syphilis. Primary syphilis gets a lesion that's a canker at the primary infection site. Secondary syphilis, the lesion repairs and it then migrates to other parts of the body. But on the third stage, which is tertiary syphilis, it then causes degradation of the spinal cord, and you lose sensations of the somatosensory, and you lose also balance, proprioception. A one of the things that you can also see, syphilis is curable in primary syphilis and the beginning of secondary syphilis with antibiotics. But one example of this is um, you guys might have heard of a guy by the name of Al Capone. Um, he actually got syphilis from one of his prostitutes. And, well, he could have been cured using antibiotics, but he was afraid of needles, that he was paranoid about needles, of what that would mean, what would be injected to him. So he never got antibiotics. So he basically got tertiary syphilis. And when he retired, he became a crazy, unbalanced man that could barely walk. So, not so that gives you a real example of when syphilis gets to that point. And it does become, when it gets to courtney, it becomes asymptomatic, where you don't have the other symptoms available anymore. The somatosensory pathways, you'll notice that we have what's known as lower motor neurons and motor neurons. And lower motor neurons will actually go from basically the brainstem down to the muscles, and they regulate your movements. So a lot of it's related to those pathways and also with how you have the basal ganglia, creating muscle tone and movement. So it's rather important to understand conceptually that it integrates with the cerebellum and such. So when we look at the somatic motor pathways, there are four basic ones. Like I said, you don't. I'm not going to ask you to recognize each one, but you should have some basic understanding of it. Like the local pathways are going from the lower motor neuron down the brainstem, and that goes to the upper motor neurons where we actually have the generation of what the effects are. We have the basal ganglia having an effect where we actually have decreases of certain neurons being affected, so we don't have motor neurons affecting. And we have the cerebellar neurons, which are then coordinating the neurons. So we have these four things going on at the same time. So one of the things that happens is we do have direct motor pathways and indirect motor pathways. Direct motor pathways go straight down to the from the cerebral cortex, and indirect goes to these other parts of the brainstem to actually go to the cerebellum and such. Now, one of the big problems is that we can also get paralysis, and paralysis is actually where we actually have an inability or a flaccid effect or spastic effect to these neurons. And flaccid means you don't have what you usually think of paralysis, where it doesn't have any kind of stimulation, whereas spastic, it actually has excessive stimulation. So, where does it all stem? Well, it all stems at the primary motor cortex in the brain, in the cerebral cortex, in the frontal lobe. And this is where you initiate the somatic motor movements. And just like we saw with the somatosensory, our hand is larger than our arm, relatively speaking. So it does actually have similarities in that. The direct motor pathway will include uh, the lateral and anterior cocospinal tracts and the cochleobulbar tracts. So this is basically, this is the key that you want to remember. It's involved in precise muscle movements. So that's where we actually have these more exacting movements, like typing, playing the piano, or even writing. Those are the things that you might want to consider. When we look at it, it goes through the pyramidal tracts, and there's over 1 million upper motor neurons. 90% of the fibers will desiccate at the medulla oblongata. That means they switch sides and they affect the opposite sides of the body. That's important. Okay, so that's what you may need to remember about this. So when we look at it diagrammatically, you'll notice that some of them go straight down and some of them go and desiccate and then go down and affect the other side of the body. Okay. Um, and we also can look at this diagram that also gives you another visual. Like I said, I don't want you to recall all the different tracks, so don't worry about the details. How does this affect what we need to know? Well, there is a problem with some of them, like MLS. MLS is also known as Lou Gehrig's disease. This is basically a disease that affects these motor pathways. It's a progressive motor weakness with the damage. How does it happen? We don't know. There's some concepts of what may have happened, but we don't know. We don't even know what to do. So there's no cure for this. The only thing we can do is treat the symptoms, and that's it. Um, So, and how did we find out about this? Well, basically, Lou Garrett was a professional baseball player, and he was in the prime of his life with, you know, very well developed muscle development, and he suddenly got weaker and weaker and weaker without any explanation. So that's why it's referred to Lou Gehrig's disease. When we look at paralysis, which is basically, if you think about Lou Gehrig's disease, is somewhat related to it. We can actually have flaccid paralysis where damage affects the muscles to actually not be stimulated. And we can have spastic paralysis where it actually causes excessive or exaggerated reflexes. So, a lot of times when we get spastic paralysis, it's caused because of damage to upper motor neurons, as opposed to flaccid, which is lower motor neurons. When it so we can actually see this, and we also have direct and indirect. So the indirect pathway will actually cause it to go to the subconscious portions of the brain, including the cerebellum. When we look at the indirect pathways, they also are descending the tracks of the spinal cord. There are 5 different tracks. That's the one key I want you to realize. And you'll notice that when we look at the common pathway, it goes using this diagram. Okay, so we actually look at that, and it's basically that overall effect is what's going to have the effect to the muscle movement of that part of the body. One of the key things is the basal ganglia. The basal ganglia is as we talked about, is in the thalamus. So one of the things that happens is the basal ganglia causes inhibition of certain movements. It is affected by the limbic system. It's affected by sensory. It's affected by cognition. So what happens is it actually causes you to have inhibition of certain muscles at a particular time that other muscles are being stimulated, which allows you to actually have language skills where you can actually do things, movement skills. But unfortunately, sometimes it doesn't work correctly. And when we have damage to it, it doesn't work correctly. One of the times this happens is with the 2 diseases, Parkinson's disease and Huntington's disease, where there's damage to the basal ganglia. And what happens is it causes tremors, it causes rigidity, it can cause irregular movements, uncontrolled movements, and it can also cause um, other types of muscle contractions that you don't expect. Now, where does this basal ganglia? It's basically right here in this diagram. When we also look at it, keep in mind it does actually affect what's going on. So if we're looking at this diagram that we looked at before, what I'm circling right here, that's the basal ganglia neurons. And they basically have an influence to reducing muscle movements at that particular time. So when we're looking at it and looking at it in the sense of normal movements, you normally, like I'm going to say, if you're going to move a muscle to create an action, you have to have inhibition of other muscles so that you can have that movement correctly. And one of the problems that happens is the basal ganglia is one of those areas that gets affected by things like rabies. That's one of the reasons why rabies will cause certain stimulations. Um, so when we're looking at it, one of the things that happens is the movements will also go to the cerebellum. And cerebellum will actually have aspects of what was the movement, what was the sensory aspect, and what was the intention. What did you intend to do? Did you intend, when you were playing darts, did you hit the bullseye, or did you hit the guy which has the bald head behind the bar, which was 30 feet away from the bullseye? Well, if you hit the guy with the bald head, chances are that wasn't what you were trying to hit. And your movements, your muscles will actually try to detect what was that movement and what were you trying to do. And what do we need to actually readjust it so that you get the movement you wanted? Or think back when you were, if you actually think back when you were very young and you were starting to walk, that movement of walking, you wanted to move just like, let's say, somebody else you saw, and you saw what the intention of how to walk was. Now, at this point in time, you probably recognize that this is such a minute occurrence in your life. But at that time, you wanted to actually have the movement to actually create that movement a certain way. And you kept trying and you readjust it and readjust it and readjust it until the point that you actually got the movement of walking the way it was supposed to be, according to your intention. Well, think about any kind of action, posture, equilibrium, they're all the same. You try to actually have the receptors detect, the receptors do that. You create a movement. That movement is then created through your motor skills, through the nerves that actually stimulate those muscles. And then you get a detection of what happened and you compare it to what you intended to happen. And then you readjust it. Well, we also have problems with the cerebellum, which could be causing things like unintention tremors and ataxia. So when we look at this cerebellum, this is where we actually have the connections between that and the medulla oblongata, which also affects posture. This is why posture was important early on in life. So, how does this all affect what's going on? Well, the overall is it affects you as far as your integrative functions like sleep and wakefulness and memory and emotions. So basically, what happens is wakefulness and sleep, which is, we kind of talked about this a bit, which is related to the reticular activating system or RAS, which is how you stay awake or aroused enough to stay awake. And if you don't, you fall asleep. That's basically what happens. And when you're wakeful, you are conscious and you're able to have normal activities. So when we're looking at it, basically things will actually affect it to actually create the reticular activating system to be stimulated. For instance, today you may have woke up. What woke you up? Was it the light? Was it the alarm or a sound? Or was it something touched you? So when we're looking at it, these things will actually have an effect. Or it could have been pain. Maybe something was painful. That will keep you awake. On the other end of the spectrum, we also have people that go into a coma, which is basically a sleep like state. And I want you to really recognize the only difference is coma patients do not have reflexes, but they're fully conscious of what's going on around them, even though they are in a deep sleep. And a lot of times with wakefulness, we actually follow a circadian rhythm, which we actually develop, and we actually have this going on, and on. And this is one of the reasons why a lot of times we actually have to have our waking up and our sleeping at intervals that we continue on a regular basis. And that sleep, one of the things that happens is with sleep is we become unconscious or our unconsciousness or our RAS becomes very low so that we actually go into a sleep. We go into a non rapid eye sleep and a rapid eye sleep, which is known as NREM as opposed to REM. And when we actually see this, we're not sure what triggers it. You fall asleep, we don't know why, but we do know the brain activity is affected by uh, adenosine levels increasing, and that affects the RAS. And caffeine will prevent the adenosine from inhibiting the RAS. Okay, and keep in mind though, that's one of the reasons why if you look at most people, they will actually they are affected by caffeine, and you'll notice that a lot of times REM occurs and we actually get sleep where we actually have dreaming, and we actually have a cycle to it. So a lot of times when we actually look at our sleep pattern, what we will notice is we have stage one where we actually drift off to sleep, stage two where we actually have fragments of dreams and we have our eyes rolling, stage three where we're very relaxed and we go into a moderate deep sleep where our body temperature and pressure will change. And then we have stage four, we are in deep sleep. And in deep sleep is where we actually see people that can actually have bedwetting or they can actually have sleepwalking. And in that stage, when if we are in that stage, typically we cannot actually wake that person or disturb that person, because if we do, it may cause them to go into a coma. And it's really important to realize. And a lot of times when we do see our dreaming patterns, a lot of times we only remember it because, well, we actually saw part of the dream right at the wake up point. Otherwise, we don't remember our dreams. So most dreams will occur during REM sleep, and it does cycle. And when we look at it, that sleep is important because a lot of times we have more brain activity at the sleep than we do under conscious conditions. So what we also have to think about is how do we learn and how do we have memory? Well, learning is our ability to acquire new knowledge and skills, and memory is a process by which we retain it. So how do we retain it? Well, a lot of times our brain has memory which is plastic, not meaning it's made of plastic. It has plasticity, which means that we learn from what we have learned already and we build on it. So there's different types of memory. We have immediate memory, we have short-term memory, we have long-term memory. And basically it's a time frame how long we can retain that information. Immediate may be like I asked you, remember this number, 1235. And a few seconds later you don't remember. Short-term memory is anything up to a couple of, let's say, hours. And long-term memory is longer, where we actually develop a biochemical change as opposed to others. And I want you to remember memory and learning is actually related to how many areas of the brain we actually have stimulation of this. So the biochemical will actually have more of that long term memory. And memory is actually where we can remember everything we've ever learned. And it's very important to understand. But we can also get an amnesia. Amnesia can actually be where we lose memory. We have two types: anterograde and retrograde. Anterograde is where we actually loss of memories, everything that occurred after a trauma. So we don't form new memories. Sort of like that movie with um, Drew Barrymore, 100 First Dates. Retrograde amnesia, on the other hand, is we don't remember things in the past. So you get new memories, but you don't remember previous memories. So retrograde amnesia is what you typically normally think of most people considering as as amnesia, where they don't remember their name, they don't remember where they live, or any other details of their past. We also have some other problems like phantom pain. Phantom pain is basically what I usually refer to as ghost pain. You feel the pain. Um, this can exist when a limb has been removed. So a lot of times, for instance, I remember somebody, they lost their leg and they feel like their toes are itchy. So that could be phantom pain. We can have spinal cord injury. Spinal cord injury can actually cause paralysis, monoplasia, diplasia, hemiplasia, quadriplegia. Um, so those are things that we see. So mono is one limb, diplasia is either upper or lower, hemi is one side of the body, and quadriplegia is all four limbs. We have cerebral palsy. Cerebral palsy usually affects individuals because of loss of oxygen during birth. And it also can have an effect by German measles, which is also a virus. It's also known as rubella. Radiation during fetal life can also cause this, but basically, what happens is you lose muscle coordination and muscle control. Um, but it's not progressive, it's not reversible, it's just affecting them from that point on. Parkinson's disease, we talked about that before. An example person that's been involved with Parkinson's is Michael J. Fox. And basically, you actually get tremors and other things. And the only thing they can do is treat the person with L-Dopa, which is and surgery and other types of painkillers. So there you have it. Um, we're gonna I hope this was helpful. Remember, get the main concepts. Don't worry about all the details. The details will come over time if you need to refer to them. So.